Hope everyone is safe and comfortable and ready for the class. So today, my session is about psychosocial aspect in palliative care. Before directly going to the session, we will have a small recap on what is palliative care. I would like to have an interactive sessions. So if there is any queries or any clarifications, you can put your queries on the chat box, or you can directly unmute and ask me questions. So, can anyone explain about what is palliative care as of the knowledge that you gained through all the before classes? So, please, anyone? Is there anyone who can tell me a small intro about what is palliative care?
So, Preeti has said it's a holistic approach to improve quality of life of patients. Mr. Devak has said it's an approach to decrease the suffering for patients and the caretakers. Anybody want to add anything more?
Yeah, I would like to add,
Yes,
Dr.
please.
Yeah. So palliative medicine is a specialized field in medical medicine wherein we are looking at ensuring adequate, rather holistic, um, management of symptoms. And when we say this, it's not just physical symptoms. We're also looking at the psychological, social aspects as well. So all in all, a holistic approach to chronically ill people. And this is all in all to ensure that they have the best quality of life, whatever is ahead of them. Yeah.
Thank you, Dr. Rohit. That was a wonderful answer. And thank you for the updates on the chat box.
Thank you, participants, for your response. So, well, as you all know, what is palliative care? This is a small definition by WHO. Here, it explains that palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other physical, psychosocial, and spiritual words. So here I'm going to concentrate on the last three terms, that is physical, psychosocial, and spiritual. And here the broader aspects of psychosocial problems will be discussed today on our class. So before starting with my class, during my home care visits in my hospital, that is in Pallium, India, even I used to hear now also that is palliative care is given only for the cancer patients or the bedridden patients. Though we have been given all the knowledge or the awareness to our patients and to the through the awareness classes to a 50% of the population, still they're having the concerns that what is they doesn't know what is palliative care. And according to them, palliative care is something which is given for only cancer patients. So the thing is, like, still the myth is there in our society that is palliative care is only for cancer patients or the bedridden patients. And also, for the practical knowledge, we have classified the categories of patients into 5 aspects, like who all should be registered or who all are the needy patients who are in need of palliative care. Based on that, I can say that palliative care or the palliative care need is provided for the ones who are having life-threatening illness or who are under serious lifestyle diseases, the disabled patients or the geriatric patients and the bedbound patients. So in this itself, almost all the areas will be covered, but still the community doesn't know who are the needy ones and what is palliative care actually. So yeah, coming to my topic, it's something which I'm concentrating more on the psychosocial aspects. In the psychosocial aspects, here is a small article which I have taken from Indian Journal of Palliative Care. You can see the details of the articles on the right side of the slide. So here, the black color bold letters, the statement is like this: the quality of life of for patients and the manner of their dying is sometimes more influenced by psychosocial factors than by physical status. So In this sentence itself, which clearly defines that somewhere in some situations, the pain what the patients are having is a point higher from the physical status. That is, the psychosocial pain is a bit increased or a bit higher than the physical pain what the patients are having. This doesn't mean that the physical pain is undervalued, but still, the pain is something connected not only with the physical but with the psychosocial aspects of patients. So, based on this article or based on the psychosocial aspects, we can directly go to the next question: why psychosocial is that much important? So here I explains that the psychosocial care is important for the patients because it is surely clear and obvious that the patients like the palliative patients will be having some sort of stress or the challenges due to the illness what they are facing. Not only patients but the families too, which is not addressed while valuing the pain scale. And how this is addressed? Is there any way or is there any pattern to address this? By identifying the proper factors related to the patient's quality of life, we can understand where the proper pain is and what all things can be done to increase their life, the quality of their life. And the third point says that if we are identifying or addressing this stress, obviously it will enhance the well-being of their life, including the patients as well as their family members. Through this support, we are reducing the level of actual and perceived stress by preventing adverse psychological and social consequences what the patients are having. So yes, it is clear that psychosocial is more important in palliative care. This is something which gives a broader aspects of pain. Here it says that pain is something, while we are assessing the pain of the patient, only the subjective pain, that is the physical pain, is only addressed, while the other components are missed out. So, what a total pain is something which the four aspects altogether concludes. It's physical is something which comes only as on a smaller portion or just a 1/4 of the portion of the total pain. So the other three aspects is something which is more than the physical aspects of total pain. So when we say a pain of a patient, we can clearly says that the patient of the pain is not only the physical pain, but some other components are there, which is the psychological, the socio-economic, and the spiritual components. So how can we assess this psychosocial components? Of course, as like the pain scale, pain of the physical pain assesses, there is some kind of assessments, tools or scales by which the psychosocial aspects can be also assessed. And it says something where the mental health as well as the social well-being of the patient is evaluated. So what is the aim of this assessment? It clearly shows where the problem arises. It helps in identifying what the problem is, which results from the illness, and the other factors which influence the patient's well-being. So for this, a proper assessment pattern should be there. For that, the first one is collecting information. This information can be from either from the patient or from the family relatives. That is, the primary source will be either the patient and the family, and the collateral source of information will be their relatives, peer groups, neighbors, etc. And the second one is after identifying the informations, like after identifying the exact area of problem, we are either strengthening it or providing the resources which is needed for the patient and their family. So this is the strategy where the assessment is done and the areas where the informations are gathered. Based on this, I have divided the area of assessment into 4 levels, which first one is the general one, second one is the patient and family overview, third one is the insight, and fourth one is the family structure and dynamics. The first area of assessment it shows that which all areas should be covered when we took an assessment scale or an assessment file. The first one is the patient and family, obviously, like who the patient is and the family related, the rest of the members of the family should be known. The second one, insight, tells like how much in-depth the knowledge the patient and the family family has regarding the diseases. The second is the family structure. In the family structure, we should know like what sort of bond the family members are having. And how much is the bond the family is having, whether they are in good dynamics or not, etc. And the fourth comes the socio-economic status. Here, like the economic status of the family, like whether there is any breadwinner, is they are having any income right now or not. Such kind of informations will be gathered on the socio-economic status. Then comes environmental assessment, like whether they are in the rural or the urban area they lives on. Then psychological distress, whether they are undergoing any kind of distress due to the illness, or before they are having any kind of history of psychological diseases or etc. Then comes the spiritual impact of illness and the interventions and plan. So in patient, I'm going to explain in detail the patient and family overview. So here, the basic demographic details of the patient and the families are addressed, like the occupation the patient is having before the illness, and at present whether is he or she is doing any kind of occupations or not. Then comes the primary caregiver, like who is the primary caregiver of the patient and what sort of relation the relation what the patient is having with the caregiver. Then insight, as I told earlier, like the diagnosis, the prognosis, and the palliative care, whether the patient and the family members are how much aware of and the level of awareness what they are having regarding the disease. Then comes the family structure and dynamics, where the genogram is clearly explained. The family dynamics is clearly understood, and whether is there any supportive systems who are helping the patient and as well as their family, and the history of illness in the family, like whether there is any kind of histories in their past generations or not. So these all areas of assessment should be there in a patient's psychosocial sheet of paper. This the broader aspects, like each aspect of the patient is explained in a much more broader manner. In the first one is the physical aspect, like as you all know, like the pain scale. Based on the pain scale, after interviewing the patients, like how much pain the patient is having, and the depth of the pain is assessed after the physical assessment by a doctor. When it comes to psychological aspects, like the mental health, emotional well-being, anticipatory grief, and coping mechanisms. Here, we can use either some screening tools like PHQ, patient health questionnaire, can be assessed for understanding the mental health of the patients. And after getting a result from the screening tool, we can go to the broader aspects, like based on the specific diagnosis or diseases, more interventions and more screenings can be done on the psychological aspects. Coming to the socio-economic aspects, here what we do is like we have a self-constructed questionnaire where all these contents are included in it. The contents are like adequate food, clothing, and shelter, whether the patient is receiving adequate food, clothing, and shelter, who is the breadwinner of the family at present, and is there any other sources of income what the patient and the family is receiving, is there any debts that the patient has, and the social support, the social supports with the government schemes and with other local financial support. Here, we should understand whether the patient is receiving pensions from the governments. Also, the caregiver is receiving pensions like caregiver pension or not. If not, we will be connecting with the local supporting systems and will be making them available with all those areas. Then comes education of the children, whether the children of the family is receiving any kind of education support or not. So these all things will be addressed in a self-constructed questionnaire where these questions will be asked to the patient and the family members, and based on that, the assessments will be taken. Then comes the spiritual aspect. Here, the connection, strength and comfort, hope and concerns, meaning and joy. There is no screening tool here, but a mere information from the patient and the family is taken, like whether they are connected with spirituality or does they having any stresses due to the spiritual aspects. So in these four broader areas, all these assessments will be taken, and based on that, we will be having a clear-cut picture in which area the patient is having problems, and the factors which are causing problems for the patient, and thereafter, a proper interventions or a plan will be arranged. So with this, we can say that the assessments will come to an end. Like the four areas of the uh, problems of the patients will be covered through taking all the assessments or through taking all the assessment, and also by use of taking screening tools, we will conclude or we will get an answer. Thereby, we will go to an interventions or plans. Is there any queries or clarification till now?
Anything you want to clarify from the participants? Please put up in the chat or speak up, please.
Go forward with the what is
So what is a
caregiver pension?
Dr. Pooja has asked, what's a caregiver pension?
So here, while we are taking socioeconomic assessments, we used to ask the patient and their family whether they are receiving any kind of fund like pensions from government. So for some patients, they will be receiving
In some
illness.
states.
Yeah, for some patients, for example, if it is a cancer patient, from our government, there is a pension called cancer pension. So the patients will be receiving cancer pension. Other than that, the caregiver will be receiving a caregiver pension from our government. So it will be purely based on the assessment, like taking the income status, whether they comes under the APL or BPL category, and based on that, based on all those assessments, we will be providing all those details to the local supporting system, that is the panchayat, and from there the papers will be moved forward to the next stage of people like the government. So thereafter, they will be getting the caregiver pension.
So I think it varies with the state. The state government provides some pensions and the central government provides some. I think in Kerala, some people taking care, caregivers are entitled to a pension support from the government if they are taking care of someone in the family who is suffering from a serious disease, like
Serious life-threatening
illness. But it may not be available in other states. So it depends on the states. So some other support will be provided from there. Dr. Pooja, I think, are we clear about this? Thank you. So,
anything else?
Dr. Bharat, you want to ask something?
Hope I can move forward with the next slides.
Please, let's carry forward.
Okay. So with this, we are getting into the end of assessments. And now I'm going to tell about the genogram. Uh, okay. So earlier on the before slide, I have mentioned like in family structure, a term called genogram. So this genogram will be explained here. So this genogram was introduced by Murray Bowen. This is actually a graphical representation, like the how many members are there in the family, or what kind of bond the family members are having inside their family. So all these things will be clearly explained with a graphical representation. And in this, at least 3 generations should be depicted on the sheet, like the 3 generations from the patients should be explained on the genogram graph. And in that, the structure, the dynamics, the strengths, and the resources of the family and patient should be explained clearly. It's purely with the symbols or with the lines, the explanation will be given, not with any sentences. So the type of informations will be like the name, age, educational, occupational profile, and their emotional relationship. So these are the symbols which we use to draw a genogram. The first square explains a male, while the circle shows a female. Connected with a line shows that they are married, and a line in between this shows they are separated. And if it is a double line, it will be a divorced couple. On the right side of the slide, it shows a circle with a straight line and dotted line is an adopted child, and a dotted line with a square is a foster child. A straight line with a triangle shows a pregnancy. Then a square with a cross is stillbirth, and a straight line with a small circle shows the miscarriage. Then a crossed one shows abortion, and the other two from the dotted area, 2 lines with the 2 circles shows they are twins. So these are the symbols which we use in a genogram to explain the family structure and the family dynamics. Hope this is clear and I can move forward. So this slide explains the emotional relationship. Here, the first one with the straight line shows a plain normal relationship. And when it comes with a dotted line, it shows that they are having a mere close relationship, but not a deep one. In third one, the 2 lines, the 2 green lines shows that they are having a very intimate or very close relationship. While the fourth one, the scribbled line, shows that they are having a hostile relationship. And if the scribbled line is a very intensively scribbled one, it shows that they are having a violence relationship. And if in violence relationship itself, if it is a scribbled line, it shows that they are having they had a sexual abuse. And the first one, only one single scribbled line, but a darkened one shows that emotional abuse. Here, the third one shows dotted line from square to circle, and the arrow is pointed towards the circle. Here, they are having a close relationship from square to circle, but there is a negligence from circle to the square. So this is a slide which shows the emotional relationship of a family. So this will be a complete genogram, the clear-cut explanation of a patient family with all the symbols. Here, Sindhu will be our patient, and we will be explaining the family diagram, family genogram of Sindhu. Sindhu's parents, Mohan and Leela. Sindhu is their only single child. She was first married to Raju, and they had a child named Saran, but Raju got passed away. Later, Sindhu married Shaji, who was the son of Kumaran and Laila. There they had 2 children, Amal and Vimal, who are twins. So this is how we will explain a family genogram. Is there any queries in this?
Is this genogram clear, or do we need more further clarification on this?
Should that color be used? Well, genogram, red, blue, and green, they match. Those colors only to be used.
No, not needed like that.
So it's just a pictorial representation. I think colors won't matter.
Colors, no, we won't use any colors. Just like in the previous slide I showed, no, this single square and circle will be shown. There is no putting color inside or outside. With this image, yes.
The emotions are not be the example which you are given in those
Yes,
the
yes, I'm going to explain on the next slide. But before that, I wanted to know whether it's clear for everyone.
And what about why is this genogram significant? I mean, why can we just write it and that no is or this is more easier? Why a pictorial representation? Why can't we just write it down on a? How does this going to help?
This would be much easier to read from in your daily practice. Rather than reading a full paragraph, this would be easier to identify.
Easier to. Okay.
So
Yeah.
you can see this picture and you can derive a lot information from that. See, you can identify who is the patient, how they are related to each and every one. So the age of the children or what age they at least their educations are, sorry, the working where is mentioned. So support systems can be identified, relation with the caregiver who is there, and what all care ways who all can be supportive to them. Those things can be identified easily from such a pictorial level. It's like a graph. You're reading a graph and reading a paragraph. So it will be easier to identify pictorial representation.
Right. Okay. Yeah, got it. Thank you.
Also, adding to that, I can also say that if there is more than one patient or two patients in a family, that also can be clearly understood from a pictorial, that is mean the graphical representation. Like when we go ask the history of the diseases and all, like if we are taking the 3-generation genogram, we can clearly understand how the hereditary diseases are coming over, and also how many got these diseases, and what are the proportions and all. Also how it is connected and all. So while drawing a pictorial, while drawing a genogram, it clearly explains rather than writing in paragraph and all. Also the dynamics, the emotional graphs also can be understood from the genogram too. So can I move forward?
Shall we move forward or any more clarification? Yes, ma'am.
Yes, ma'am. We can move forward.
Okay, thank you. So this is the slide which shows the emotional bonding also. Here we can see both genogram, simple genogram, the family structure, and also the emotional relationship is explained. So I think this one can be explained by any one of the participant.
So can you identify the patient?
Sindhu is a patient because you have.
Yes.
Okay,
so can you please explain their emotional relationship and the structure of the family?
Shall we go back to slides for a moment and
You're not able to recollect.
Okay. So this is the symbolic one, like how the members are explained, the male, female, their relationship like married, separated, divorced, and the children like adopted child, foster child, pregnancy, stillbirth, miscarriage, abortion, and twins. So this shows the emotional relationship, the normal relationship, the interconnected one, the intimacy relationship, the hostile one, the violence relationship. And this was a simple, only the structure is explained, no emotional explanation, emotional relationship explained here. This is a simple one where only the structure is explained. And in this one, in this family, we included the emotional relationship also. So can anyone please do a try?
I'll try, ma'am.
Sure.
Please.
Okay. So the relationship of Sindhu with Raju was normal because there's only one single line plain. Mm-hmm. And with Sindhu and Shaji also was normal. There's only one single line.
Okay.
And between Vimal and Sarath, it is 2 lines. So it was a friendship and a close relationship. Vimal and Sarath, 2 lines they had.
Okay.
Okay.
And between Sarath and Veena and Subhash, they had violent because it's red, red and cross. Not violent. It's a hostile relationship between Veena.
Is it
Ma'am,
between
Sharad?
Sharath
No,
or
not between Veena. Sorry, it's between Shaji. Shaji and Sarath had a hostile relationship.
okay, okay.
At the same time,
Shaji was normal with Amal and Vimal, his own sons. But with Sarath, because it was from Raju, so he had a hostile relationship with that one.
Okay. Did you see a small arrow here?
Yeah.
So the hostel
And
relationship is from Shaji to Sharath.
Sarath. And he's neglected the child.
Yes, yes, yes. And what is this green line? Choose.
The green line is a very close relationship between Sindhu and Sharath, 2 lines, so it's very close between Sindhu and Sarath. Between Sindhu and okay, these are new persons.
Okay. So here it's a double line with the green color. So their relationship is very much strong. Like they are so
Strong.
much intimate. Sindhu is having a very strong intimate relationship with Sharath and also with her other two siblings, that is Bindu and Indu.
can you identify the relation between, actual relation between Vimal and Sharad?
Vimal and Sharath is close, no? They're friends. Their friendship, it's 2 lines.
So
Yes.
in terms of relationship,
They are like relationship means you mean they are like stepbrothers.
yes.
Okay, yeah.
Okay. And what happened to Raju?
Raju passed away. That's why you have.
Sure.
Okay. Also, there is a small line from Leela to Sindhu also.
Single line is a normal relationship.
Yes, yes. Okay, very good.
So with just few lines and process, we got a good history from this. So it's very easily identifiable. I hope now you got to understand why the genogram is much important.
Subhash, Plumber, and Veena are also siblings. They are children of Kumaran and Laila.
Subhash and Veena. No, Veena is the wife of Subhash.
Yeah, wife. Yeah.
Okay, they are having only 2 children, Subhash and Shaji.
Okay, and Veena is a wife of Subhash. Okay.
Subhash, yes, yes.
But still, with the relationship between Veena and Shaji, you have shown off as a. Even this is the relationship between Veena and Shaji also.
Even with Veena and Shaji,
Hostile.
also they are having a hostile relationship.
Hostile relationship.
Yes, yes.
And
yes.
Shaji and Subhash also have a hostile relationship.
Shaji and Subhash also having an hostile relationship.
Clear, ma'am. Now it's clear.
Okay. Is there anyone who want to go for another trial?
Nishant Kumar has also answered because Sindhu is the patient. Our support are Hindu.
Can I try? Can I say it?
Yes, yes, sir.
Yeah.
Yes, sir. Please.
Yeah. I think the family starts with Mohan and Leela. The Leela was Mohan. Mohan died, and Leela has a daughter called Sindhu. Correct. Then Sindhu married Raju, who was a coolie worker, and Raju died. Then she married Saji. Correct. And then Sindhu had a son whom she is very close with, Sarad. She's also close with Bindu, her which is a homemaid, and she's also close with Indu, who is also a close relative. I mean, she's close with because they are sisters, I think, so if I'm right.
Yes.
Yes, yes.
Then Indu married Mani, and Bindu has married to a Ravi, who is a bus driver or a driver. Now, from a second marriage, Saji was the son of Kumaran and Laila, who was, both of them have died. Saji had 2 more siblings. One sibling, I think, Subhas, who is a plumber. Her wife was CG. Now, Saji does not have a good relationship with Subhas and Veena, and his support he and Sindhu, he and Sindhu have 2 twins, Amal and Vimal, And the twins have good relations. They have codependent kind of. Vimal is kind of codependent on Sarad, but the Saji does not have good relations with Sarad. Is always stepson. That's what I think.
Excellent, sir.
Okay, so very
Yeah.
good,
So,
sir.
just to make it clear, so the Sindhu's family starts from Mohan and Leela, their parents. Mohan and Leela has three children. The eldest one is Indu, second is Sindhu, and third is Bindu. And Indu is married to Mani, Bindu is married to Ravi, while Sindhu was initially married to Raju, who was a cooler, who unfortunately expired, and they have a child, Sharat, who in that relationship. And after that, remarried with Shaji, whose parents are Kumar and Laila, who has two children, Shaji and Subhash. Subhash is married to Veena, and Shaji got married to Sindhu and have twins, Amal and Vimal. These three, Vimal and Sharad, the two stepbrothers are in good relation, but Shaji doesn't like Sharad.
Yes, yes. He's having an hostile relationship.
And Sindhu's two sisters are in good relation with her, and she also has a good relation with Sharad,
Sharad.
son in first relation.
Also, Vimal is having a mere relationship that is not that much close, but yeah, they are having some kind of intimacy with Sharad. So here we can see that three generations are there, like Mohan Leela first generation, Sindhu second generation, and their children Amal, Vimal, and Sharad, who comes under the third generation. So this is how we explain a family diagram with structure, with dynamics, etc. So can I go forward? So earlier we have seen how the family is connected, like the how the members are the connected inside the family, how members are connected and their relationship. Here in Echo Map, we will see how a patient and family is connected with the social groups. So this is also a pictorial representation where the patient and their family members is connected with the social environment, that is the outer society, and how they are getting other supports from the community. So this is how the family will be connected, like with the health service, with the neighbors, with workplace, government services, community services, religious institution, friends, clubs, school, volunteers. So as same like before in the genogram, here also we can explain the structure as well as how they are in good dynamics or not with the society or the community areas. So this is another pictorial representation, and here we have connected with the social groups. Can anyone go and explain how this family is connected with the social groups? This is also simple as before.
I can give it a try.
Sure, ma'am.
Please.
Yeah. So for this particular family, I think we're concerned with the wife who we are talking about. She has a very strong relationship or support from the church. The whole family has a complete good support from the church
Yes, yes.
and a very weak support from the panchayat member. There is stressful and hostile relationship from the neighbors to this family as a whole. Followed by, I think that's it for the whole family. Now going into the good support, they have very good support from positive or normal support from the volunteers. Moving into individual, the wife has very good support from the self-help group, followed by weak support from the public health center. And yeah, so with regards to the husband, he has good support from the colleagues and I think that's it for the husband and wife. Now, with regards to their children, the son has good support from college, from friends, which the daughter also has good support from friends. The daughter has good support from school, very strong support from the youth organization for the daughter. I think I've completed that. I'm not sure.
Okay, ma'am. Okay. So is there anyone who want to give a trial?
Yeah, try one more time.
Sure, sir.
Yeah. So this is a nuclear family with mother, father, and their two children, the male and the female. The mother is affected. The family has good relationship with the church. The and the good relationship with the church. The whole family has a good relationship with the church. The son has a good relationship with his friends, his schools, and his youth organization. The daughter has good relationship at the college, at and at the college, and they also have good. The husband has good relationship with the colleagues, and the wife has good relationship with the self-help group, or she gets support from. They don't get along with their neighbors, and volunteers are supporting them. I think that is what said. I think I said the son is square, right? The son has good relationship with his college, and daughter has good relationship with friends and also at school and with youth organization.
Okay, sir. Thank you.
Mhm.
Anyone more? Okay, so I think
The relationship between the husband, wife, and the children also is normal, I think. Or is there just an arrow, or we just have to show it's
the relationship between
the
sorry, ma'am?
husband, wife, and the
Husband,
children
wife.
also. It's normal. It's positive. That's it. No?
Okay, okay. So here, this is a nuclear family. So here the dark line goes to the wife. So she is the patient. So they have two children. Elder one is the son, and younger one is the daughter. They are having, the whole family is having a strong relationship with the church and vice versa, because the arrow points to the two sides. Like the family is having to the church as well as from the church to the family. So coming to the panchayat member, here there the panchayat member is having a weak relation to the family, but there is no relation showing from the family to the panchayat member. Only weak relationship from the panchayat member to the family. Then coming to the neighbor, like the neighbor is having an hostile relation to the family. No relationship is showing from the family to the neighbors, but neighbors are having an hostile relationship to the family because the arrow shows to the family. Then comes the volunteer. Here, the volunteers are having the normal relationship to the family. The youth organization, both the family and the youth organization are having a strong bond, since because the arrow is showing to the both sides. Coming to the school is having a normal relationship to the daughter. Also, the friends is having normal relationship to the daughter, and the son vice versa. From the both the side, they are having a normal relationship. Coming to the college, from the college, the son is receiving a strong relationship, and vice versa from son to the college. From the public health center, the patient, I mean the wife, is getting a near support, but there is no line showing, no arrow showing from the wife to the public health center. And going to the colleagues, the husband is receiving a normal kind of relationship from the colleagues to the husband as well as from husband to colleagues. From self-help group, the wife is receiving some sort of support. So this is how the graphical representation of the family to the outer community or to the other social groups. Is there any queries or clarification in this?
Yeah, good evening, ma'am. I have a query. I'm Dr. Suhaila.
Yes,
So,
ma'am.
at what point we had to make this genogram? During the first visit itself, we need to dig into all these details. or during subsequent visits? Because church, panchayat members, neighbors, all this relationship we had to ask leading questions, or once we make rapport with the patient and family?
Ma'am, actually, after the initial assessment and all, we will come to a conclusion like there is some kind of problems rather than the physical pain what the patient is having. So when we come to a conclusion like that, we need to assess the psychosocial economical areas of the patient. So when it comes to the psychosocial economic areas, we have to find out which all areas the patient or the family is getting support from, like from inside the family and also from the outer society. And when we are taking the assessment from the outer society, this graphical representation or this echo map will help us in understanding which all suppose the family is receiving and which all is not getting. Also, like what are hostile relationship the family is having with the surrounding areas. So based on that, we can get a conclusion. And with the strength, like here we can clearly understand that the family is having a strong relationship with the church, with the youth organization, and the son is getting a strong relationship with the college. So when some problems comes with the education or with the economical problems and all, we can directly go ask the support of this church and youth organization so that they can help they can help in some or the other way to the family. So like based on these assessment and based on these graphs, we will get an idea like which all areas are strengthened and which all areas are weakened. And based on that, we can put an intervention plan. I hope it's clear. Hello, ma'am.
Yes, ma'am.
Okay.
Thank you.
Okay, ma'am. So anything else anyone should ask?
Ma'am, do we work on their relationships also? I mean, if they have a hostile relationship, do we counsel them on the, like we ask, do we advise them on those also? As
Ma'am, if that problem is causing a stressor for the patient, then obviously you will go for a counseling session.
okay.
Okay. Anything?
Good evening, ma'am.
Hello, sir. Yes, sir.
Yeah, I wanted to ask whether is it possible to take this much history in all the patients because in our country there are very few palliative care centers and there is too much rush of patient. So primary physician takes all this history or support staff take this history?
Sir, it's actually based on the need of the patient. If the need demands us to take the assessment, then obviously we will go and inquire whether they are receiving all these supports or not. And after that, if we wanted their support, like the community support to get into the patient and the family, then we will try to connect with those sources. It's purely based on the need of the patient and the family.
So it is not for all patients.
Pardon, sir?
Sir,
So it's not for all patients, I mean.
No, sir. Purely based on the need of.
Okay, thank you.
So,
Yeah. Sir. Sir, did you ask about the community support or the psychosocial aspects?
Psychosocial aspect, this graphical formation.
you are asking whether the genogram or these
Yeah, well, is it possible to take all this history in all patients? I wanted to ask.
I think the answer we'll have to ask for like the first question we ask, what is palliative care? So in palliative care, we are supposed to take care of not just the physical issues. If you are going to look for the social, psychological and other issues, these histories might be helping you a lot. So ideally, I would suggest this has to be assessed in every patient. But it's not possible. It might not be possible in every setting. But it's ideally these should be assessed, and these will help a lot into getting to the all aspects of the patient suffering. Anything, Dr. Neeraja?
So as I mentioned before, physical aspects just come one of the four other parts. So the rest of the three comes as the psycho, social, and spiritual things. So for that, we need to take an assessment. And later on, if the patient is having too much problems from the background of the psychosocial, then the deeper assessments like this should be happened. Whether they are connected with the community or what else areas should be strengthened or not.
Okay, thank you.
Okay. So with this, we have entered the genogram and echo map. Next, we are going to the caregiver. So here there is a definition which says that there are only 4 kinds of people in the world. Those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need a caregiver. So respect those individuals, acknowledge their complex role, never dehumanize them by calling them bystander. Recently, there was a study done by a doctor here. So in that, we understood that the caregivers are also undergoing some kind of psychological as well as social issues. And when we take a patient, obviously the family members are also connected to the illness or the stresses what the patient is having. So the caregivers are also going under high rate of psychosocial issues, and hence the psychosocial aspect should be given for both patients as well as for the caregivers. So respect those individuals, acknowledge their complex problems, and also don't dehumanize them by calling bystanders. So with these all assessments and with these all studies, what all interventions can be given to the patients and their families? We can provide them information, we can psychoeducate them, we can provide supportive counseling, we can follow up them, provide them bereavement support, a rehabilitation process, facilitation, and liaison. So these all are the interventions which we provide for the patients and their families after taking all the psychosocial assessments. So with this, we have concluded the theory part, and next comes a case study. So before that, again, I would like to ask, is there any questions or any clarifications which you need to ask regarding the psychosocial aspects of patients and their family members? How to take their assessment? What all the information that should be asked? Any clarifications? So here a question got raised like anticipatory grief and how we can get details. So this is something which comes under the psychological aspects of patient and the caregivers. So here the first primary tool which we used to have for the psychological assessment is the PHQ questionnaire. So here when it comes to the anticipatory grief, this is something which comes under the bereavement support provided for the caregiver. So it's a bit longer process, like some few stages are there, like how to express or how to heal or address the grief of the family whose patients had been expired. I think the grief session. So it's another sessions where much more detail of the grief loss is explained, and this anticipatory grief will be explained on that session. But yes, we are having some screening tools for that, and it's a step-by-step strategic process where we deal with the caregiver. So this doubt can be clarified on that session, I think so.
Dr. Bharat, can you please explain the question?
Sir, I am saying that at the time of end of life care, when patient asks regarding the prognosis, the patient, then which group is more reliable, yeah, more responsible for among the this discussed echo map?
Asking me about the echo map, like which is reliable, either echo map.
Yes, ma'am. Yes, ma'am.
So the first interviewing or the questions will be asked to the patient and their family members. So with that itself, we can understand whether the family members are knowing about, are they aware about the illness or not. If not, we will be going with the collateral support system, that is either the neighbors or the peer groups or who all are the members connected with the patient and their family.
Okay, ma'am. Thank you. Thank you.
Any other questions?
I think then we can move on to the case presentation. Sorry, okay, then we'll go for the case study.
So, this is a small case study. A 56 years old lady, Mrs. A, has been diagnosed with CA breast in 2016. She has undergone mastectomy, referred for pain management. She looked very anxious and had no idea about palliative care. The comorbidities are diabetic since 12 years, coronary artery disease, fracture on leg due to fall in 2019. She's a widow and her children are having a hostile relationship with her. She lives in a rented house. So this is the small details about a lady who has undergone mastectomy and she's having some psychological issues like anxious and all, and she doesn't know much about palliative care. Also, some other comorbidities are also present. She's a widow and she's having two children, but they are in a hostel relationship and she lives in a rented house. So, can you please explain the psychosocial aspects of this case study of this lady? What are the problems, what are the psychological problems that this lady is having, the social problems the lady is having, and the spiritual problems? You can either unmute and explain or just put the answer on the chat box.
Loneliness, financial worries.
Okay, ma'am.
Ma'am, no one to take care of her because so there's no caregiver.
Okay. Can you please explain like in which all aspects this comes? Like these are the symptoms which comes in the psychological aspects, and these all are the problems.
Social, no caregiver will come in a social aspect.
Okay, I think first we can go with the psychological issues.
Okay, psychological issues will be that she's very anxious.
Okay.
And since she has no idea about palliative care, so she'll be lost. I mean, doesn't know what exactly it is. That will again be psychological.
Okay, ma'am. Anything else anyone want to add?
And another psychological aspect will be a hostile relationship with her children.
Okay.
That will maybe worry. It may be worrying for her, like she may be feeling left out.
Okay. Also, she is living alone in a rented house. So that may goes into loneliness feeling also.
Loneliness and depression, maybe depressed
Yes,
also.
yes, ma'am. So anyone else want to add more in psychological aspects? Okay, thank you, ma'am, for your answer. Next, we can go to the socio-economic aspects.
Social aspect is, ma'am, there's no one to take care of her. There's no caregiver. She's living alone.
Okay.
She doesn't have any friends. I think there's no friends, so there's no one else or
Okay. So she's socially inactive.
inactive. And again, that's it. There's no friends and family. You have not mentioned anyone else also. I mean, so she's just socially isolated, maybe probably.
Also, I think she will be having so many economical issues too.
Yeah, that also will come because financial issue. No one to earn, and her children will be not there to support her. So there's no one else to earn, and this treatment may cost her, and she may be worrying on. So that will come again on both. I mean, she may be worrying on the financial aspect also. That will be psychological. That will be social economic. Sorry.
Okay, ma'am. Okay. Anyone else?
Yeah, the disease itself, carcinoma, breast, and mastectomy can add on to her anxiety, and follow-up treatment as well can cause more of economic burden on her. And comorbidities, diabetes for the past 12 years, coronary artery disease. So for treatment for comorbidities can also add burden to her economic status.
Okay, ma'am. Thank you.
Thank you.
So these are the four aspects. I have explained few points from the case study. So coming on the physical aspects, she will be having physical pain, fatigue, lack of sleep due to pain, difficulty in walking as she had a fall on 2019.
tamam ne açıyorsun sen?
Also body image issues also she can be having. Then coming to the psychological aspects, it was mentioned like she's living alone. So obviously she will be having that isolation feeling. She's emotionally weak, anxiety about the future. Also, she is not clear about the palliative care and about the prognosis. So, which will be causing her more stress. Due to the prognosis and palliative care, also, she is having so many multiple illness. So, these are all the problems she will be having on the psychological aspects. Coming to the socio-economic aspect, she's having a strained relationship with the family. So there is no social support system. Since she's having a fall in, she's not been able to go for a job. So again, financial instability will be there. Living in a rented house, so that also increases her economic burden. Low accessibility to the hospital and absence of the caregiver and support system. Then coming to the spiritual aspect, she is having extreme spiritual distress, like why all these sufferings are happening to her. She has lost faith in God, loss of connection with family, again giving her that lost feelings, no significant person in life to address her problems, and no memorable or joyful events in the family. So these all problems again making her spiritually also stressed. So this is how we explain the four aspects of the patient. I mean the physical, the psychological, the socio-economic, and the spiritual. Anything else you want to ask me regarding the case? Yes, I saw.
No, ma'am. No, ma'am. We are clear.
Someone
We are
has
clear.
raised a hand. Ask me. Do you want to ask me anything? So can I move forward?
Yes, ma'am.
So, points to remember, that is, evaluate our interventions. Though we are going with the assessments, or though we are going with the plans after getting some conclusions up from the assessments, it should not be permanent all over the time. So we will be going under repeated assessments based on the need and the problems the patient will be having. So hence we need to evaluate our interventions based on the assessments what we are taking in between. Assess how the patients and families are benefited. Though we are providing them interventions or with the problems what we have identified, we need to check whether the patients and the families are getting with the are they getting benefited from the interventions or the plannings what we have been provided. Also, assessments have to be revised and updated. We are taking a first initial assessment, and based on that we are moving forward with the whole time. That doesn't make any change, or that doesn't make any change in their quality of life. We may need to take more assessments as we go, and based on that we have to update the interventions and the plans that we have provided for the patients. Reach out for help if needed. It should not be like every time the interventions what we have been provided will be fruitful or will be accurate for the patients. So on that time, we need to reach out for the help based on what the problem the patient is having and the criteria what the patient is asking. There is an art and science in psychosocial care, just as in medicine. So with this, I would like to conclude my session. I think we'll be having one more case. So handing over to Dr. Arjun.
Thank you, Neeraja. We shall move forward for the case presentation. Dr. Ruhi, are you ready?
Yes. Yes, Dr. Arjun, I'm ready.
Yes, please.
Yeah. So good evening, everybody. I'm Dr. Ruhi Ravindra Kumar Dange, and I will be presenting the case today. So this case is with regards to Miss X, 70-year-old female with diagnosis of carcinoma right breast, stage 4, T4B, N1A, and M1. It's a mistake there. Bilateral lung metastasis with minimal pleural effusion, multiple vertebral and iliac with femoral metastasis, and a known case of hypotension. Next slide, please. Yeah. So her presenting complaints to the center was with right breast lump, which was increasing in size since December 2022. There was lumbar region pain associated for about 4 months now. She had difficulty in ambulation due to the pain. She had on and off breathlessness for the last 2 months. She was diagnosed with right breast cancer in the month of July. This is in the same year of 2022 with CA with metastasis. So she had come into our center for purely palliative care because she had opted out for any. Next slide, please. So her history of illness, technically her history had taken course over 1 year. So in January 2020, there was a mustard size, painful, apparently in her language, a small pimple noted on the right breast. She had no symptoms associated with it. So this gentlewoman is living in the village while her only son is living in the city. So she had left that unattended, and she had moved to live in the city with her son once her husband had passed away. So in the interim, according to her, she had seen that this lump was increasing, but she had not made any consultation for the same. Direct jump to March 2022. She had an incidental hospital visit due to she had an alleged fall at home in the village. So in the interim, she was with her son for a couple of months, and then she had moved back to the village. And here she was living alone in her ancestral home while the son was in the city. So she had a fall in the village, and during her visit to the hospital for the fall, the mass was observed by the relative, and it was taken into further evaluation. And here they had got a provisional diagnosis of breast CA, which was requiring further evaluation. again, which was left because she was not willing for this. In June 2022, a jump from March to June 2022, she had come into the higher care medical facility. And this is when she had started showing signs of increase in size of the breast mass, now with pain in the lumbar region and difficulty in ambulation. Here she was diagnosed with right breast CA and she was referred for radiotherapy and she was consented for surgical resection, but the patient was not willing to undergo any active treatment modalities. At this stage, what I would like to add is that she was overall doing okay. She was able to ambulate, but she had difficulty in it. She was able to speak. She was more or less looking like, she was not very advanced in terms of her medical concerns, although her diagnosis said otherwise. Next slide, please. So in the examination, the pertinent positives that we were able to see, there was a right breast mass, there was irregular border, mobile redness was noted, there was axillary lymphadenopathy, there were supraclavicular lymphadenopathies, there was pleural rub, right more than left, there was warmth, tenderness in the lumbar region as of noted on the time of examination. Next slide, please. So this was the investigation which was done for her a PET, and we had seen there were multiple metastases throughout. There was malignant neoplasia in the skin of the right breast. There were irregular nodular thickening in the left pleura with metastatic deposits with minimal pleural effusion. There was metastasis in the right upper lung and the middle lobe, metastatic lymphadenopathies in the mediastinum, periportal, and right supraclavicular region. There were multiple osseous lesions in T4 to L4 vertebrae with T4 to L4 vertebral compression. So at this particular point in time, she was on step 1 to step 2 of pain management with painkiller. She was with multivitamins and food supplement. She was complaining of loss of appetite, so on an appetite stimulant. Conservative management to pain. She was considering music therapy, dance therapy, art therapy at this time. Professional psychological counseling session is something that the family had come in for, requesting if the music therapy, dance therapy, art therapy, professional psychological counseling, and if an Ayurveda massages to calm her down at this particular stage could have been possible. That is a treatment modality that she was looking at our center. Next slide, please. So these were her concerns, which she had raised upright in our discussion with her. So despite of going through multiple times of, having an opportunity to go get herself checked, even at this stage where she had denied cancer, her question to us was, "Are you sure I have cancer?" So when she was discussed on this and spoken about, what are the options that the previous doctor had given her, she said it is not loss of a gender identity, and she would definitely not be looking at it because there are cultural aspects to that. She said that within the span of 2 years, her husband passed away, and then she had all of these things coming up. So she felt that she was always a religious woman, and why was this happening to her at this particular period of time, ever since her husband's death? She lost her husband 2 years back, and her children, one of the son is in the city living far away. And she felt that after the loss of her husband, the children were unable to spend time with her to her content. And now she felt that ever since her diagnosis, where she has come now, it was a very short period of time, and she felt that the time was passing too soon. She said that medicine couldn't cure or diagnose her issue right at the beginning. And she felt that even if she took any of the medications or any of the treatment modalities, it was not going to help her in any way. God had chosen to punish her, and she thought that she was anyway going to go through with it. So there was no point of taking any treatment. She also felt loneliness as her social interaction had also gone down post her husband's death. She felt that there was no one to hear her out, and she was feeling that she was trapped in her own thoughts, and she felt that she was going to pass away the same way. She felt that identity of living with progressively terminal illness, the life had no more meaning. And she kept requesting, if all of this could just end in one go, and if there was anything we could do to help her end her misery. There were on and off suicidal thoughts. She said about, why couldn't just God take my life? And if there was something that she could do or we could do to just kill herself or, take the drastic measure. She was also looking at not trying to eat because she said probably not eating would be one of the way that she could end her misery. Next slide, please. She was on these medications. She was on antihypertensive. She was on multivitamins. She was on, like I said, basic pain management only. She was on a protein powder and MSET SOS. One that we have missed out here was her. She was on lactulose as well, but I think that's missed out here. She had a very different kind of approach to taking medicines. She felt that these medications that were being given to her were also hindering her from passing away. So despite of her condition looking progressively deteriorating, she did not complain of any pain or elicit any pain parameters or any signs of excessive pain. So her pain management was also very basic, as we can see. Next slide, please. So the concerns here were symptomatic management. Now, since what we are seeing in the, according to the medical background versus what she's eliciting, they were quite different. Or quite, it was quite, there was a vast gap in terms of what we saw and what she was feeling and what she was discussing with us. So is symptomatic management adequate here where we're looking at pain, breathlessness, anxiousness, poor sleep, poor appetite, dressing? And are we able to holistically guide and counsel her through these days? Are we doing enough to eliminate the social isolation? And what would be the role of multimodal team approach in such a situation where especially she is not very willing to go ahead with medical inputs or medical people at this particular point in time? Next slide, please. So in summary, she was feeling that she was well 1 year back, although the diagnosis started from about 2 years of time. The progression of disease was quite furious after the husband's death, and she felt it kind of aligned together. She was ignoring the symptoms and she was unwilling to take further medical treatment due to her disbelief in modern medicine and cultural reasons. Currently, she was receiving pain management with holistic psychosocial counseling only because she was not willing for any other active treatment. Next slide, please. So discussion points. This is something that I was thinking about, at that particular point in time. It was so difficult as a medical personnel to have a communication with her directly because she had a block for modern medicine. And looking at her, given her age and given her condition, there could have been so many things that we could have done from the medical perspective. But the patient had very clearly made a decision to not go ahead with it. So we were at a standpoint where we as medical people felt that probably, we could have helped her, but she was not willing. And all of her discussions kind of showed that even though her medical condition was deteriorating, her psychosocial need for support or the psychosocial aspect played a major role towards the end of time. And I think that was a little bit of concern for a team, especially medically spearing team, to handle that. So, so communicating to her what is happening naturally is something that we did. We tried to do as much as adequate symptom management that she was discussing on. We tried discussing on alternatives to drug therapy because, she did not want to go ahead with any sort of active treatment because she thought we were delaying her death. And we were wanting to know what were the best options, best options to find which could meet her physical and emotional needs at this point. And something that we felt, we were not equipped was to let her know that it was all right to cry. It's all right to express herself, encouraging the expressions of, affection from the family. I felt that we were not adequately able to manage the family, the connection between the family and the mom. The continuum of adding value and quality to the remaining days of the patient's life. Listen to the last wishes and regrets of the resident, meeting the needs of the patients and relatives who are grieving, and be present with the resident and the family if they want support. So these were certain areas that we felt we were able to, and we were not able to cater a lot to. But we felt that we were severely, we were not equipped to handle such a standpoint. Next slide, please. Yeah, so this is just something that came to my mind when I was thinking about this one difficult case from my time of being with my particular center. I think this was one case which kind of left all of us a little haywire. So going back, if you could just go back to the previous slide, Dr. Yeah. So here my discussion, these are pointers that I have put from my end, but the questions here was how do you approach this kind of a patient where you clearly understand that the psychosocial need kind of overtake the medical aspect? How can we as a team be equipped for it? At the same time, how can we give the best outcome to the patient in a situation like this? I think that would be the biggest question that we had, and I would like to discuss in this class about.
Thank you, Dr. Ruhi. Now we are open to inputs from the participants.
Ma'am, she was against modern medicine. So, could we have asked her, like, why was she against modern medicine? Did some past experience, or did she have something which had experience? I mean, if you're against something, you would have had some experience regarding some bad
Yeah.
experience.
Yeah, so I think it was moreover about her husband's death also. So what had happened was her husband also passed away at a very short duration of time. By the time they found out, he was already, you know, he was already in a very bad state, and I think he passed away after 2 months of the consult. So I think that kind of was a change point in her life, wherein, even though she found out her findings very early, she was kind of little resistant to modern medicine because of that. Yeah.
We could have given her examples of people who have surviving and living with cancers. There are a lot of people who, when diagnosed early, like they live, and at least they're comfortable. See, we all have to die one day, but at least there are a lot of survivors. So could we have explained, sort of celebrities are there who have survived, and they're that would have restored her faith.
Yeah, so we do have a counselor on board, and I think the counselor and she used to have a little bit more of, like, a very headstrong arguments on the same lines, where she, as you can see, ma'am, she's quite she's able, and even her pain management medications, as you would have seen, are very basic. She was not ready to kind of listen. She was always having, like, a straightforward mind and discussion. So it was getting difficult to kind of get through to her. And the counselor also felt that, she had kind of built this walls around her head, and, she had a response to everything. Yeah.
Yeah, so we respect patients. We say,
Right.
we just say about this patient. So we can just say her that whatever you do, whatever you decide, whatever decision you take, we are there for you, and we'll try to keep you comfortable. That's the only thing, last thing we can do.
Yeah.
Yes, exactly.
Yeah, our team kind of resorted to the same. We had to kind of respect that, although I think we felt under-equipped because we were not able to get through to her, but we had to, at the end of the day, like you correctly said, we had to respect her wishes in terms of not taking medicines or not wanting to get any kind of support. Yeah.
Yes. At the end of the day, it's her decision, but it has to be an informed one. So make sure whatever the things that or what are your plans, you have to explain it out. Yes, definitely she is having some issues with modern medicine. So ideally, the first thing I would suggest to do is explore her issues and explain to her what we can do that, or talk to her. Like many often we see people against modern medications, like especially analgesics, the fear of causing damage to the kidney. So they often come to say that taking these drugs will injure my kidney and I will end up without a kidney and a chronic patient. So discuss, inform them there are drugs which may not be causing this, and these opioids may not be a reason for that. Our priority would be to look for your pain, make you relieve the pain, and such things can be. So it's explaining to them and informing them what are the possible outcomes, and if we can always just try. It's as you had your communication sessions in the last time. It's not always 100% possible, but we have to try our best. We can give a fully informed thing, whatever happens or whatever plans to them, and it's finally up to the family. We cannot force them to take the medicine. We are always usually on an advisory post. We advise to them, show them these are the things. We make maximum open to them and let them decide. When it's better also look for the problems which are causing their concerns and address it if we can.
After understanding this, what I felt is like this person is having more of psychosocial spiritual issues. So first and foremost, we can do a detailed reassessment, like the identifying the exact area or what are the problems or what are the factors that is triggering her into more and more psychosocial issues. So based on that, we can identify her strength and weakness. Like there will be some kind of strengths for her which she would like. Maybe before identifying this diagnosis, and after that, like how she is coping with after getting understanding this diagnosis. So we need to assess like what is her area of problems and what is her area of strength and weakness. Based on that, we can plan an interventions accordingly. Then the second thing what I felt is like here there is no proper communication with the family members. I think so. I think with the children and all, she's not having a proper family and there is no good dynamics with the family members. So the thing is like we can do individual session with the patient as well as with the family separately, and understand what they are having any kind of caregiver burdens or something like that, or what are the thoughts or triggering things which they have towards this particular person. And then we can get into a group sessions where we can improve their dynamics inside their family members. So which would also gives a good like it will be a rewiring inside their family. And the third thing which I would like to suggest is like she's a person who is already connected with the spiritual area, but right now after the death of the husband, she has gone down in that area, which again making her put into more stresses. So we need to assess whether she is connected, the echo map. Here I can refer the echo map. What are the areas where she is connected with the social groups? Does she have any peer groups like alumni, something like that, or she is connected with the neighbors or the colleagues and all? So we can add them into this circle where it will give a more stress-free life for her. Also, if there is a guide, like a spiritual guide where she is so much connected with, we can identify that person, and later on we can have a session with them also, like connecting them more with the spirituality zone.
Like a chaplaincy service.
Yes. So also, she's already undergoing so many kind of therapies like art therapy, dance therapy, and all. First, we need to look whether she's interested in those things, or is there something which she wants to do. So based on that also, we can direct her to some other kind of therapies, including some kind of psychological medications too. If she's having, because she's having some suicidal ideations, so need to assess whether any kind of she's going through any kind of depressive moods or a mood disorder, something like that. So after assessing that, if needed, we can provide a psychiatrist consultation too.
So Dr. Pooja has asked whether can we introduce some CFS patients to the patient. If they can motivate her if they can motivate her with a good success story, and if she is willing, yes, we can suggest that meeting such self-help groups would be helpful for.
Because otherwise, I think she's already having some kind of body image issues. So giving like making them interact with other people also will give her some kind of motivation.
Make sure the other end is also in a good motivating person, or this might backfire.
Yes, sir. Actually, we tried to do that, but I think it kind of backfired. Within first few couple of minutes, she just called the nurse and she said, "I want to go back to my room because I think this is making me feel more. I'm not feeling good about this. I would like to go back to my room." Yeah.
So first thing I think we can do is like identifying her strengther areas. So based on that, we can prepare our intervention plan.
Ma'am, identify her strength area means what exactly do you mean? Like what areas?
Like it will be like taking the history in detail, like before the diagnosis, what are the things which she is interested too much, or what are the hobbies which she likes, or what are the things which she used to do while she's to channelize her, or like what are the coping mechanism which she earlier used to do, and whether is she doing anything right now at present or not. So, like after interviewing, we have to create a good rapport with her, and later on, through detailed intervention, I mean, through detailed questioning, interviewing, we will get a bit details about what she is want to do and her strength zones. Like everyone will be having some kind of strength zones. So, based on that, we can prepare some kind of action plan.
Okay, ma'am.
Anything more you want to discuss on Dr. Ravi? So I hope we were able to help you with this.
Yes, I think the session before kind of helped me through, sir. I've got the answers and understood the situation.
Happy to hear that. And Dr. Chaitra has stories of medical marijuana in India. I think studies are still going on, and some there has been use for cannabinoid medications are useful for some type of intractable pain and nausea, vomiting. I'm not an expert in that, but I don't think it helps with any of the psychosocial issues. But it has been proven to help with refractory vomiting, nausea, and even in sometimes pain issues. Cannabis has been used. So I hope we are clear and we are past the time. We can wind up the session.
Yeah.
Thank you, Neeraja. Thank you, Sripriya. Thank you, everyone, for a wonderful interactive session. See you all after 14th after the IAPCon.
Yes,
Have a
sir.
good day.
Thank you, Neeraja. Thank you everyone for joining in. So we will not be having a session till 14th of February now. We will meet again on 14th of February. Till then, everyone, take care. Bye-bye.
Bye, ma'am.